Welcome everyone to the KCQVIC Forum. I don't remember which number of the forum this is for us, but we've been doing this since 2018 monthly. So we're very excited to have you all here today. Before I kind of get into before we get into our agenda, we are going to kind of just go through a little bit of what the KCQVIC is and does, and then we'll introduce our speakers. So for those of you who are not yet familiar, the KCQVIC, or Quality and Value Innovation Consortium, has the vision of bringing multiple stakeholders together to improve the quality and value of healthcare. And we're supported and brought together through partnerships with BioNexus KC, with UMKC and the Next Gen Precision Health Institute, and with the KU Frontiers Clinical and Translational Science Institute. So what we're really trying to do with the KCQVIC is really achieve kind of the quadruple aim, but in Kansas City. And so ultimately, you know, at our core and center, we're really trying to improve health for patients and populations by, you know, improving their health outcomes, by increasing and making better the patient experience, or by reducing and lowering the costs of healthcare broadly, and providing a better provider experience and decreasing burnout. And really what we've been doing and are trying to do is really create a learning health community. We are bringing together, you know, really all the stakeholders that have a voice at the table. So healthcare leaders and providers, community-based organizations, researchers, payers and purchasers, policymakers, public health professionals, philanthropy, industry, and really, you know, we all have kind of with the commonality that we're all really trying to help the patients here. And, you know, the strategies by which what we've been employing over the past few years and what we'll aim to be doing continuously to achieve our vision is really kind of centered around these three key activities. So first, we have these regional quality improvement projects. Many of you on the phone are involved with these or know of these, but we have two projects, and these are multi-hospital projects. This is a map of Kansas City here on the left. And as you know, most of you know, we kind of straddle two different states, Kansas and Missouri. And so we have a number of hospitals on both sides of the state line. And in red are all of the hospitals that are participating in our opioid management, or KC EPIC project, which is, I won't go into great detail, but it is an ED-based initiative where we have patients with opioid use disorder who present to the emergency department, and we stabilize them and connect them to the KC EPIC program, which includes peer recovery coaches who help them to navigate and connect to treatment in the community. And we're basically doing both the implementation of those projects tailored to each hospital, and then also we are doing mixed methods evaluations on those interventions. And then our second project is transitions of care for heart failure. And that one is across you know, both state lines. And it really involves currently three different interventions that we're doing to impact the transitions of care for heart failure. And at highest level, those include the Managed Services Network, which we are launching a randomized quality improvement trial at Truman Hospital next week on, as well as CODE-HF, which is an ED-based pathway with risk stratification for patients with heart failure. And then also the Payer Disease Management Coordination, where we coordinate the handoff between patients in the inpatient setting to payer disease management programs for care outside of the hospital. And so those regional quality improvement projects really fill the broad majority of the work we do. But in order to kind of do that work, we also recognize the need to develop training for our researchers who help us to do those projects. And so we have this training program, which is called TIARA, cutely named, of course, but it's training and implementation or actionable research approaches. And that is, the materials do live in our website for anyone that's so interested. And, you know, we developed those and then they were deployed with one of the, you know, I call her the godmother of implementation science, and I so see she has joined us on the call, Dr. Ann Sales at the University of Michigan and former editor of the journal Implementation Science. And, you know, we just love her. But, you know, she helped us to kind of develop and deploy this training, which is so important for both the researchers and also clinicians who want to really understand how we overcome and how we identify and overcome barriers to implementing changes in practice. And then we also have our kind of what you're all here for today, our dissemination and engagement aspect of the QVIC, where we meet monthly and do forums on different healthcare topics that are important to all the stakeholders in our region. And today's is, really exciting on strategies for healthcare provider behavior change, because we know it's a really important and difficult topic to, actually effectively manage in the real world setting. But each of these forums, how we structure them is kind of uniquely where we bring different stakeholders together who all have experience or on the issue. So they might be a healthcare provider or a payer. They might be a community-based organization or a patient, a researcher. And now that we've been doing so many of these virtually, we've had the great luxury of being able to invite a lot of national leaders and speakers from all over the US and beyond to kind of also present and give their lens. And so it gives us an opportunity to hear from all the different stakeholders and their perspectives, but then to kind of come together at the end and see what we can learn from one another and how we can come up with new strategies to solve things. So so the KCQVIC Forum, this is just kind of our layout, I guess, for 2021, what we've been doing, where we're at. We're in May, which is on strategies for healthcare provider behavior change. Our next month will be on trauma, informed care, and ACEs, just so you're aware, and then you can see the rest of our agenda for the year. So I'm looking at the clock, because I'm already over. So I'm gonna really fly through these so I can get us back on track a little bit. Just as we kind of, oh no, and sorry, I have to minimize this screen. As we all know in health services research, there's a gap between evidence-based clinical practice and what actually happens in the hospitals and clinical care settings. We know it's multifaceted, it's psychology, it's industrial organizational psychology, it's different behavior change, it's health economics. There's so many things at play here, and there's a lot of different motivators of provider behavior change. And this last article that was in the Milbank Quarterly kind of identifies things like in terms of the providers, their mastery, their autonomy, their power, and relatedness, social purpose, potential demotivators, and then also financial motivators. And so we know there are just a myriad of factors that impact what actually changes provider behavior. And this is not one size fits all, one solution fits all. And we also know from the literature that it takes a lot of time in order to get evidence into practice. And in fact, we know from the Morris et al. Article here that it takes us about 17 years actually to move from getting evidence into practice, which is too long, and we need to be faster. And then, I'm going to go a little quicker here, but we also know that when you look at a translational science spectrum and where science is and where we are along the translational pathway, that there are all these valleys of death, we'll call them, as these authors have. Meslin and colleagues, they published about these in translational science that, for a number of reasons, studies fail at different time points. And so these are, really what brings us to kind of implementation science, which, we have the definition here from Ann Sales of, the science of planned human behavior change under organizational constraints. We know that we really have to understand the determinants or the barriers or facilitators in order to best tailor our implementation strategies to impact practice. And I'm still trying to fly through here a little bit. And so as you'll hear today from our speakers, there's a variety of these strategies that we can implement in order to change behavior from providers and also increase the likelihood that the evidence gets taken up in practice. And so you'll hear from our speakers on a number of these different strategies that include some of the things I'll list here in addition to others. And these are, facilitation and coaching, education and training, learning collaboratives, data feedback and benchmarking, payer-provider partnerships, and alternative payment models, which include a number of the things we're talking about today with accountable care organizations, financial incentives or disincentives, shared savings programs, pay for performance or quality, and the CPC Plus program. And so with that, I would like to, over time, and I apologize, hand it over to my friend and former colleague, Dr. Betty Fout, who is a principal associate in health and environment at Abt Associates, who's going to give us kind of a policy research perspective on ACO models and evaluation findings from the ACO models broadly. And the floor is yours, Betty. I'll stop sharing.
All right, thank you. Can you hear me?
Yep.
And can you see the slides now?
Yep.
Okay, great. Thank you, Stacy. It's really a pleasure to be part of this, and I really appreciate you reaching out. It's excellent to see you as always, but this looks to be just a fantastic forum. So as Stacy said, I work at Abt Associates, and I work on federal and state contracts related to value-based care. I'm a health economist, and my focus is on using quantitative analysis to support CMS, mainly CMS, but also some states in decision-making, whether it be effectiveness or the best way to implement a model or program. And in this short period of time, I hope to introduce you to my firm, Abt Associates. If you have not heard of it, quickly describe the landscape of the CMS Innovation Center, some of which you might already know, but I'll go pretty quick. This Innovation Center is the birthplace of many of the alternative payment models, the Medicare ACO models that we will talk about. And we'll discuss findings from a recently completed ACO investment model, of which some of the Kansas, Missouri ACOs participated, and then really touch briefly on home health value-based purchasing, even though it's not quite so related to ACOs, but it is something that Abt works on, and CMS recently announced its intent to scale it nationwide. So first, Abt Associates, we are celebrating our 56th birthday this year, so we're going into middle age. We were founded by Clark Abt as a research firm that was focused on social reform. Through the decades, we've grown and evolved, but have really stayed with the same mission to serve as a trusted advisor to federal and state agencies across a wide range of topics. So we have projects in education, labor, agriculture, environment, and international as well. In the health group in which I am located, we frequently work with CMS, CDC, AHRQ, and SAMHSA, and we help to implement and monitor and evaluate programs and provide technical assistance. We have a multidisciplinary staff of researchers, a lot of economists and other social scientists, and also clinicians, especially in our health group. So innovation models. So CMMI was created in 2010 by the Affordable Care Act with the intention of accelerating movement towards value-based care by creating a mechanism in which new payment and delivery models could be tested and scaled more rapidly than the pace of the time. The funding was renewed for another 10 years, so bringing the total to 20 billion over 20 years. In the last 10 years, CMMI has really released dozens, many models. Not all of them fit into these three categories here: primary care, episode-based, and ACOs, but they do kind of cover a fair number of these type of these alternative payment models. There's been a recent article by the former CMMI director who summarizes the progress that CMMI has had in fulfilling its charge in the last 10 years. So of the dozens of models, and I think he names 50, or he notes that there's 54, just 5 have been found to yield substantial financial savings. So the vast majority lost money, and many did not improve quality. So if you lost money, but you improved quality, that's still kind of a win for CMMI, but many did not do either. The article is very good and very short, and it does a nice job of explaining why this is the case. And it's notably mostly due to challenges with generating a good benchmark, because it's very hard to predict spending. And then also the voluntary nature of the vast majority of the models. So if you lose money, you can drop out. And then notably, 2 of the models that were associated with substantial financial savings were ACO models, and one of which we'll talk about today. So Medicare ACOs, there are many different types of ACOs across the country, and some of them are commercial, Medicaid. Even within Medicare, there are several types of ACOs. Generally, ACOs are groups of providers, a group of providers that come together and they agree to coordinate and manage the care for Medicare beneficiaries in return for sharing and savings that they generate, subject to a benchmark, a financial benchmark, and then maintaining or improving quality of care. The providers receive a portion of the amount saved, and that's their inducement to transform and better coordinate care. And if they agree to take downside risk and that they also share in losses, they can share in more of the savings. And downside risk can sometimes be mandatory. In the beginning of the shared savings program, it was not, and most ACOs chose not to participate in downside risk. Currently, the shared savings program has the most ACOs, 477 in 2021, of which is Centris Health of Kansas City. There were two models. So shared savings program is a program. It's not operated under the Innovation Center, but the Innovation Center did operate or implement two models underneath the shared savings program, which is the advanced payment model and the ACO investment model. Both of these were targeted towards smaller ACOs. The ACO investment model is targeted towards more rurally located ACOs in places where accountable care and value-based care had not really touched yet. So its job was to induce providers to form an ACO by providing them with upfront monthly payments to help cover the costs of investing in technology, hiring staff, and generally building the infrastructure needed to better manage and coordinate patient care. And you'll see some of the Kansas and Missouri had some ACOs that were in the ACO investment model as well as the advanced payment model. Then there were two other models that the Innovation Center put out, which were the Pioneer and NextGen models. These were targeted at more advanced groups of providers that were capable of taking on more risk. And with that risk, they were able to take on some flexibilities and benefit enhancements and generally some changes to the way that traditional fee-for-service Medicare operates so that they could better manage the care. And CMMI wanted to test that they gave them those flexibilities and those benefit enhancements that they were able to better spend on the beneficiaries and lower costs and improve quality. So we're going to focus in the next few slides on the ACO investment model because APT has helped CMS to evaluate this model for the past 4 or so years. So as I said, this model is targeted at smaller, rurally based providers that might have not had sufficient funds to start an ACO. So CMS gave them a lump sum amount and also a monthly ongoing amount based on the number of attributed beneficiaries for 2 years, which they could spend over 3 years. This amount was meant to be paid back to CMS with any shared savings that the ACO earned in the end. And the ACO would use these funds to invest in ACO infrastructure, hire staff. They showed a variety of different types of spending that they had to report on. So this slide shows that of these 45 ACOs, like CMS was successful in recruiting them to be in places that were more rural, that had greater disadvantage, had lower rates of value-based care, lower rates of Medicare Advantage, fewer other ACOs located there. So they generally were smaller and really did need the funds in order to operate. In the end, about half of the funds that CMS paid out in AIM payments were paid back through their shared savings, and the rest either had not yet been recouped or would not be recouped because the ACO did not renew in the shared savings program. The evaluation findings, I won't go through all of them, but the bottom line is that our evaluation team found that the AIM ACOs in totality saved $382 million over 3 years, compared to a comparison group of beneficiaries that were eligible for ACO attribution, but were not attributed to any ACO. And then this also netted out any payments made for shared savings and also for AIM payments. So CMS saved a decent amount of money on these AIM ACOs. These savings were driven by reductions in hospitalizations, ED visits, skilled nursing facility use, generally the costly institutional-based care. And we did not find any changes in quality, meaning it did not go down, but it did not go up either in what we assessed. The key takeaways from the evaluation are located here. So we found that AIM ACOs were able to save money overall, but really only half of them realized shared savings in terms of their financial savings. So this is an area that has also agonized the Innovation Center, the kind of the difference between evaluation results and financial results, but they're a good reason for that. And this is the reason why you do need an evaluation. But only half really realized savings. And at the end, most of the ACOs actually departed the program after their 3-year agreement period. They needed to stay those 3 years in order to not owe back AIM funds. So if they stayed those 3 years, whatever funds they had not paid back were forgiven. But had they stayed, they would have to renew for another shared savings program renewal period, which would put them into a faster track to downside risk. And a lot of the ACOs felt like they were not ready to take on downside risk and then having to share in the losses even after those 3 years, even if they were successful. At least they were not willing or ready to do it in their current form, because we did find that a lot of the participants of these AIM ACOs actually just joined another ACO and continued in the shared savings program, and likely joining a larger ACO where risk could be kind of covered across many participants rather than just a small ACO. So that's definitely one of the findings that we looked into. And you can read the full report at this link and read more about AIM ACOs at this website. So upcoming ACO and ACO-like models, CMS is building upon their ACO models, one with the Community Health Access and Rural Transformation, or CHART model. This model is going to be aimed at rural communities transforming care there, because rural communities face really unique challenges that were even more exacerbated by the pandemic. This kind of has a two-pronged approach that's really to kind of hospital global budgets, and an ACO model that's very similar to the AIM model. And then a model that's currently going on is this global and professional direct contracting, which is not an ACO, but it's really the next generation. It really builds on the shared savings program, next gen ACOs, and features of Medicare Advantage. Really a big model that takes into a lot of complexities going on there. It began April 1st, 2021, but they're looked to be not taking applicants for 2022. So we're not sure what direction they're going to go, but it's been in the works for a long time. And I know there's been a lot of providers who are very interested in it. Lastly, I wanted to touch on home health value-based purchasing. It's a bit of a pivot from ACOs, but in talking with Stacy about what would be of interest to this forum, she noted that my experience with HHVP might be worth bringing up quickly. So APT has been helping CMMI implement HHVP since 2015. This is a mandatory model for all home health agents, all Medicare certified home health agencies in 9 states from 2016 to 2022. The agencies compete with other agencies in their own state and within certain size cohorts on quality. And based on their performance, they will see a boost to their fee-for-service claims reimbursements in a payment year, or they will see a decrease in their fee-for-service claims reimbursements if they perform lower than their cohort. And performance is measured both by achievement and meeting some, like a median, a benchmark, and also improving by meeting their own or exceeding their own baseline. The evaluation found savings and found substantial improvement in quality scores, and therefore CMS did expand this model recently and announced that no earlier than 2022, the HHVP will be expanded nationwide and be mandatory. And we expect more details to come out in the forthcoming home health proposed rule that should be in June that APT is helping to work on right now. So this concludes my presentation. I appreciate your attention, and my email is here. I'm happy to hear from anyone and any questions at all. Thank you.
That's wonderful. Thank you so much, Betty. That's great. Okay, so now we'll turn to our next speaker. We'll be hearing from Chad Moore, who's the Vice President of Strategic Partnerships and Network Operations at Blue Cross and Blue Shield of Kansas City. And he'll be providing us with a payer perspective on the evolution of Blue KC's value-based care models. The floor is yours, Chad.
You're on mute.
Can you hear me okay there? Yeah, I switched my screen share before I unmuted. You can hear me okay, Stacy?
Yep, you're good.
Okay, perfect. And you can see my screen.
Yep.
And hopefully not my really ugly inbox, which I tried to quickly hide before I hopped on, but I don't think I did. So thank you so much, Stacy. Really appreciate you inviting me to come on and speak today. I'm going to give an overview of really Blue KC's value-based care models. I'll probably go through the first few slides pretty quickly. They hit on many of the tenets of which Betty just hit on, so I won't spend a lot of time there. I want to talk more really about some of our specific models and where we see success with those models, how we're looking to accelerate value-based care, and then also talk some more about provider change and how we think we can best influence that. Just a little bit of background. So Blue KC is is Kansas City's largest commercial insurer. We've been around for a while, about 80 plus years. Although the journey on the value-based continuum is a lot more recent than 80 years. We've got about 1 million members or so. We're a licensee of the Blue Cross and Blue Shield Association, and through that association, able to provide a national network of providers across the country. I'm pleased to see in the participant list a number of our provider partners that we work with, including Joe Watson, Joy Jacobson, and Luke Harris, who are colleagues of mine that are deeply engaged in the value-based work that we've been engaged in the last few years. So happy to hear from them today as well. Let's just kick in. So again, I'll give just a quick overview of our value-based care tenets when we think about, the move from fee-for-service to value at Blue KC. Briefly touch on the HCP land APM framework, which again, Betty touched on a couple of those tenets, and then how we look at accelerating value at Blue KC and where we think that can best be achieved, and what are some of those attributes in the network that we're looking at to help achieve that. And I will, Stacey, I'll try and keep track of questions that they come in and address them along the way, but I think we've got time at the end for Q&A, but I'm happy to try and keep an eye out for those as we roll forward. So again, as Betty mentioned earlier, right, when we think about healthcare delivery models at Blue KC, and we began evaluating how we were going to shift our large fee-for-service platform and networks into the value-based continuum, these are cruise ships that don't turn on a dime, right? The fee-for-service infrastructure is long, very old and very embedded in the infrastructure of not just Kansas City healthcare community, obviously across the country. So but everybody recognizing, and frankly, with the good work of CMS and CMMI as part of their alternative payment model rollout is, the value equation is something that is a great uniter amongst us providers and payers. And where we can find value in the healthcare system, I think we can all agree that's a good thing for both patients and members. And so we see great synergy around how we achieve the ultimate goal of greater value in our healthcare delivery models. It's about aligning performance and outcomes, and how do we measure those, and how do we create incentives that align with provider behavior on a reimbursement chassis that makes sense, right? Obviously, there's a high focus on quality of care, so we continue to include quality measures as part of our alternative payment models that we roll out. It's an equal part of the value equation. And as I mentioned, obviously, we want to reduce that fee-for-service volume over time and create a much greater emphasis on the value continuum. Just obviously, everybody's well versed in it, right? Revenue optimized by rate and volume, old fee-for-service models, shifting to the right once you focus on those value-based care models that heavily optimize outcomes and value together, and while at the same time aligning those incentives so that the revenue is still there, properly incenting providers and health systems. Some of the outcomes that we've seen in our value-based program, and I'll mention, I've got a slide at the end that talks more about the breadth of our programs, but our patient-centered medical home program is a very mature program, began in 2008, 2009, has really evolved along with our providers in the market, and as well as participation in the CPC Plus program. But what started as a pilot program more than a decade ago with a couple of primary care practices in Kansas City have grown to attributing more than 350,000 members, 30 plus practices participating. It's really a foundational program that we use heavily as we begin to evolve our system contracts into greater value-based APMs. That medical home program is key. And what we see in those medical home programs are some of these outcomes, right? Increased patient satisfaction because of that coordinated care between their providers with the patient being right at the center, increases in quality and affordability of care. It's been interesting as the patient-centered medical home model has evolved to an advanced primary care model, now moving into different areas, primary care first, more greater forms of capitation, that of quality and affordability continues to increase, right? Which for us, when we think about, principles of continuous quality improvement, right, you're always working at it. And ultimately what we see is greater savings and higher quality year over year with our value-based programs. And that's not obviously Blue, that's a provider payer partnership that we work very closely with our providers to achieve those goals. Again, it's encouraging that appropriate healthcare utilization, right? Is it at the right location, the right reasons, right? Again, that's very much a collaborative partnership model that we take with our network providers, ultimately trying to promote healthier communities and better managing chronic conditions. Just real quick, I had some more slides. I slimmed these down because I think as I was looking at the participant list, I'm sure most, and I know of quite a few folks on the call are participants in the Healthcare Payment Learning Action Network. But that's really when we began thinking about our value-based program portfolio at Blue KC. We used that framework to build our APM models. It's a great collaborative network of stakeholders that are using the same language and using the same measurement in order to see where we have success in these value-based models. And so, as I won't go through these, but as we think about the APMs that we have developed at Blue KC, we try and categorize them under that same framework. Obviously, moving from left to right, fee for service, no links to quality and value, all the way over to your population-based payments, greater forms of capitation, and risk, downside risk for providers, such that we get to a place where we truly have alignment around incentives between financial incentives and outcome incentives linked to quality and care delivery. What I'd tell you is at Blue, we have a current state that if we think about that continuum, and sorry, this is getting small, is the bubble on the left being that fee-for-service category 1 bubble is still pretty big. Future state, and notice there's intentionally a date left off of that, is we hope to increase those APMs across that land framework such that we have more population health-based payments. Understanding that with our providers, right, this is a conversation where we're moving and we're trying to move as aggressively as the providers can move with us, knowing that the market and group demands from our customers very much want to drive at greater value in the healthcare dollar. And so again, these are things that don't happen overnight, but what we've been able to achieve with providers and systems, and we're going to hear from Jill and Joy, but at Centris, is that we've been able to push our providers along that continuum pretty successfully. And I'll talk a little bit about some of the things, the keys to success there that we see as we move down that continuum. So just thinking about accelerating value at Blue KC, as I mentioned, we started with that medical home program that has grown to an advanced primary care model that is really focusing on greater quality measures, greater emphasis on advanced quality metrics, but also a greater impact on focusing on cost containment. And where we take costs out of the system, there's a greater sharing of those incentives with the provider as well. Same with, I mentioned the CPC Plus program, which is also grown. I think Blue KC before my time was was the payer that engaged with that CMS payer partnership in order to leverage more federal dollars and resources to town. And we continue to promote that program very heavily. We have a great team of healthcare consultants, transformation consultants that work very closely with our primary care practices to continue to find value in those payer provider partnerships. I put on here our health system performance program. One of the things that we focus so heavily around primary care as our foundational value-based program early on and still continue to focus there very heavily. But as we have more attributed lives in those primary care medical home programs with our systems, we are beginning to look at how we can evolve that program to tie to system incentives. And by that, I mean our health systems. So we're engaging in conversations across the network right now with our hospital partners to understand how we can work together to leverage the medical home program from an attribution standpoint to align incentives with those health systems as well. And we look, the value that we're looking at there with our hospital partners is really around trend management. So when we think about total cost of care and population-based payments, it's a combination of advanced quality metrics and how the system is also managing that population. And the future then is about tying incentives and payments to how that population's trend is managed. That for us, and with large group clients, mid-market, small group, right? That's driving at that goal of affordability for our members and groups. I won't go too deep into the centrist arrangement because that is one in which we have a risk-bearing shared savings agreement, because I think Jill is going to touch on that. But I joined Blue just 4 years ago Monday, and as one of the first tasks that was handed to me was an outline of a shared savings risk agreement between Blue KC and my friends at Centris Health. And over the course of the next 12 to 18 months, we turned that into an agreement where we are using our attributed population, our attributed medical home model as a foundation for how we're paying incentives to that ACO today. And it has been, we've had a lot of lessons learned out of that. I'm sure Jill's going to talk a little bit about that and can address questions there. But that really is one of the only downside risk agreements in the market on the commercial side. And a credit to Centris for being able to leverage 3 independent health systems coming together under that clinically integrated model to begin working on the value continuum together. Other systems are certainly moving in that direction as well and have been moving in that direction, but to bring 3 disparate hospital entities as well as a large IPA together has been really a significant organizing influence in the community. One of the things that I call out, and I will wrap up here too, so I don't get us off track if I haven't already, is that that when we look at value of Blue KC and think about what we see as supports for success there, really data sharing is key, and we are getting better at that with our provider and our networks. That is no small task in order to accomplish a bidirectional data sharing agreements, whether that's from the financial data and claim sharing that we're able to do today, but also bidirectional, receiving clinical information so that we can meld the two together, as well as the provider or system can bring those two together, ultimately to get to those actionable insights. For us, when we see progress in those value-based models, it's really about how are we leveraging that data with our hospitals and providers in order to achieve that value-based continuum. And there is a strong correlation there, obviously. Also an increase on those incentive payments, right? We can't just take away fee-for-service components without replacing them with key value-based payments. And we've had good success with keeping those things in line as we move down that continuum. I mentioned our healthcare transformation consultants. These resources work with the practice of managers and the providers. So one of the call outs Betty mentioned earlier was around provider education, training forums. That's really what's happening at the transformation consultant level, is sharing of best practices and what's working in those APMs and beyond. And then finally, just a new set of value-based program data analytics that we've brought to bear over the last year, and are beginning to work with our systems. So not just in claims data and what we're mining from claims data and how that may be impactful for in a fee-for-service world, but really taking that to the next level and thinking about value-based program data analytics that's looking at things like globally appropriate measures from Dr. McCary that we're going to be pretty focused on over the course of the next 12 to 18 months, and just continuing to evolve that set of measurements so that we, don't get stagnant in any one program. I'm going to pause there. I didn't see any questions come through, Stacy, but happy to answer those at the end or whatever is appropriate. Thank you.
Yeah, thank you so much. Yeah, and if anyone does have any questions for any of our speakers, please do enter those into the chat, and we'll try to answer as we go or save a little time for the end as well. So thank you again, Chad. So we're gonna move us along here onto now hearing from Centris and the provider integrated network perspective. This one will be advancing care delivery to thrive in value-based payment models. We'll hear from Jill Watson, who's Executive Director of Centris Health of Kansas City, alongside Joy Jacobson, who's the Director of Ambulatory Quality at the University of Kansas Health System. So thank you both, and the floor is yours.
Okay, let me try to share my screen so I can run our slides. We have them.
It's a little faint to hear you.
Together. All right, are you able to hear me?
There we go, yes.
Are you able to see slides?
Yes.
All right, very nice. Well, I'm Jill Watson, and thanks, Chad, for teeing this up so nicely. We didn't even coordinate, and look at that. Here it is, all teed up, ready to go. So Joy and I are happy to be part of this, talk a little bit about what the Centris experience has been and how we're trying to advance care delivery to thrive in value-based payment models. And I appreciate the background that Chad shared, and happy work anniversary, 4 years. 4 years and 3 amendments, Chad. So that's how it goes in value-based care contracts for sure. So let me get to my next, maybe, there we go. A little bit, I've presented to this group before, so if you have been on these in previous months, but this is a slide that is familiar, but it gives just a little bit of background around what the Centris model is and who the players are. Chad called them out, but it is North Kansas City Hospital, Advent Health Shawnee Mission, University of Kansas Health System, and about 35 independent clinics, many of which were already organized under the Kansas City Metropolitan Physician Association, which it didn't occur to me might already have been called out as well in Dr. Fad's presentation. So that group was happy to be the first Medicare ACO in Kansas City. I had the pleasure of leading them before I joined Centris, before Centris was a thing, actually. And funny, to Chad's point about aligning, that is partly how that happened, is that at KCMPA, those outpatient clinics realized quickly that in order to get to the kind of savings that needed to happen, to be successful in the Medicare ACO, they were going to need to align with inpatient providers. And that's how we stumbled into the conversation that eventually became Centris. And I mentioned in the chat that we were pleased to repay the full advanced payment amount that we received from CMS in our last year, and then promptly shut it down and joined Centris and started a new ACO. So some of what Dr. Fout was saying is very much part of the local experience here as it relates to ACOs. So I will talk a little bit about, not too much though, if you have questions about this, I'm happy to go into it in comments, but didn't want to take too much time about what's the leadership look like. We're owned by 3 health systems, as Chad mentioned. We have a services organization and a physician network, and I have the physician network. The physician network has the contracts. The first one that we started with was Blue Cross and Medicare at the same time. So we had essentially about half of most primary care practices patient population right out of the chute, which was different than a lot of clinically integrated networks that we had researched, who put together a clinically integrated network and then hoped that they would get contracts. We had contracts right out of the chute, which was very helpful in focusing just focusing our thoughts and our efforts and all of that. So that turned out to be a good course of events. So physician leadership and governance is certainly important. We have a quality care program that is integral. IT, we have a shared population health platform that is important. And then we couldn't do, we wouldn't be an ACO without value-based contracts. So to this point, all of Centris's contracts are value-based contracts. We do not do fee-for-service contracting through Centris. That is a choice. Some clinically integrated networks do that. Centris chose early on not to do that. So we are only talking about value-based dollars in the Centris contracts. We have, and sort of how the magic happens, I guess, within Centris is through a series of committees. The physician leadership is an extremely important part of what Centris does. We still hold to it 4 years later. We have two main committees. Each of them has subcommittees off of them that sort of help you understand what are the important components of thinking about value-based contracts. On the quality side, we, right out of the chute, had a subcommittee that focused on ED utilization. Continuum of care used to be called post-acute. That was, you know, just as it sounds, looking at the post-acute environment. That, after a couple of years, became continuum of care because it was clear from the work they were doing that we needed to be looking at more than just post-acute. We need to be looking at what is happening in the inpatient setting, but then also what's happening at the ambulatory setting after the patient moves through the post-acute experience. So we've seen a nice evolution in our committee work, and which I think is a healthy indicator of how our systems are moving. As Chad said, it's a cruise ship for sure, and they are, you know, slow to move. Lots of moving parts and lots of things like a pandemic to deal with in the middle of it. So, so very pleased with what that evolution is looking like. We also have a committee that's on heart failure. Being where we are, I guess, we have a high prevalence of heart failure in our population compared to other Medicare ACOs. And so that, you know, continues to make sense as a condition that we focus on. Right now, we are in a process that we're calling a subcommittee reboot. And I think, again, it's just an indication of our healthy evolution of where we're at. But we have started sort of reimagining what will those committees do in their next iteration. So I'll get more into that in then the next slide or two. And under payment transformation, we have a group that thinks just about pharmacy costs. We have risk on the Blue Cross contract that Blue mentioned, that Chad mentioned, for medical expense, but also pharmacy expense, which has been a giant lesson learned for us in a number of ways. Just understanding what all of that means and the different populations and all of that definitely requires us to have a separate look on that altogether. Risk adjustment is a giant piece of value-based care and understanding the risk of your population compared to other populations, compared to itself in other time periods. It's all part of the art and science that goes into value-based care. And so we have a robust effort to help our practices understand the risk of their population and to make sure they're accurately capturing that risk so that we can communicate with our payers on how sick or how healthy our population is through the language we have to do that, which is claims codes. And lastly, we have a committee on network integrity. You know, the best clinically integrated networks and the best at value-based care understand how to maximize their network. And it makes sense to try to do that, keep patients within a network so that you can guarantee the same kind of approach to utilization and just member service all around. So we have a committee that looks at network integrity as well. So what happens in the committee, I guess, is where the magic happens, if there's any magic at Centris. I'd say that one of the most relevant tools in our toolkit is transparent performance comparison. And Centris made a point early on to commit to showing comparative performance by clinic, by provider, by health system, by all of that. We don't blind anything. We never have blinded anything. And if you think back 4 years ago, that was still a little bit, cutting edge, maybe bleeding edge here in Kansas City to do that. But that has continued to be an important piece of what we do. We show comparative data at every possible chance we get. We're trying to help practices see what they do well, and clinic, health systems, practices, providers, all the way down, what they do well, what they could do better, who's doing better than they are, and they might find a way to learn from them. We spend a lot of time bringing to them evidence-based education around industry standards and finding peers to our participants in other areas who are doing interesting things and helping them understand how they were able to move from their fee-for-service workflow to something that's more in line with the value-based or pop health workflow. There's a lot of best practice sharing within our subcommittees and outside of that. They talk quite a lot with each other on their own. And that's one of the things that they appreciate the most, I think, about Centris, is the opportunity to learn from each other and test something, see how something has worked in our local market before they jump into it as well. And I'd say the other thing that we do really well is we tie our financial incentives to performance. Chad mentioned that in his comments about how our contract with Blue encourages, has financial incentives that are tied to our performance. And Centris passes that on down the line. When we earn incentives tied to performance, we try to pass that on in the exact way that we earned it, so that there's no dilution of effort or any mix-up of what produced the incentive, so that we can continue to get better at it and have that be a motivation. We do have the opportunity to distribute incentives, which is that is half the excitement of Centris. And why would 3 systems come together to try to figure out a new payment model? It's obviously hoping that it would work, and it is a potential for new revenue. Thankfully, we are having that experience on a number of fronts. We early on made a decision, and I say we, the physician leadership made a decision early on when Centris was set up back in 2018 to distribute incentives 90% based on performance and 10% on attribution. So that means most of the dollars come from how well you did or didn't. And so if you're not getting all the dollars, it's because you didn't do as well. So that was their most aggressive option that we presented to them. And that's the one that they selected. And as I said, we pay out incentives the same way that we earn them whenever possible. Again, trying to really just pass that on and to send a clear message through that incentive payment of how those dollars are earned, and which is really the essence of what is the model trying to produce that's different than before. So we do that whenever possible. I would say it's not always possible, because sometimes data isn't available all the way down to the provider level, or sometimes there are difficulties there that make it hard to do that as well as we would like, but that is our intention. And then I think it's important to mention that we distribute to the tax ID number. So our relationship is down to the participant level, the TIN level. not the provider level. And then each 10 distributes further down from there. So that is what I was going to cover today. And I will turn this part over to Joy. And she's going to talk about, you know, taking on down the next level. So if Chad is the payer, the contract is with Centris. Centris has a relationship with each tax ID number. And then this is how one of those tax IDs is getting the change to happen all the way down to the care team level where the patient sees it and feels something different. So I'll turn it over to Joy. And if anyone has questions, I'm happy to answer those after.
Good afternoon. Hopefully you can hear me. I will try to run through this fairly quickly because I know we have one more speaker. But I really think it is nice how this agenda has been set up because it really kind of tells the story as we kind of look through all of these different programs and as they kind of build upon each other. So I'm going to talk a little bit about our kind of journey through this as we are kind of preparing for, you know, value-based care and really advanced care delivery. And so, you know, I'm going to go back, you know, I feel like we began our journey in about 2010, and it really was focused on it in the patient-centered medical home model and how do we prepare and add services and programs to support as far as an extended care team. So you'll kind of see that right-hand side. You've heard it before. You've got the patient-centered medical home, CPC Plus, that comprehensive primary care plus model that we've been participating. We're in our 5th year, and then preparing for primary care first. And I think with that changing payment model, right, we are trying to get those programs and continue to monitor and enhance those programs that really support our providers. And so when we look at that, and I'm going to spend a little time talking about what those programs are, but we've continued to kind of evolve. I know with patient-centered medical home, that's kind of when we started launching our transitions of care program and following up on all hospital and ED discharges and our chronic care management program. Doing a lot of that telephonic services in between visits. So those programs were starting to be built back, you know, a little bit into 2012, 2011, as we were kind of getting started. And at the same time, which I always think is interesting, you know, we were also launching meaningful use, right? So we were trying to capture data. We were trying to implement electronic health records, implement health information exchanges and, you know, patient portals. And you kind of connect the dots because a lot of that was happening at the same time, which I think is allowing us to really focus on quality performance and enhancing workflows and really supporting the care team. So I kind of always think back to that time because we were all kind of going through that process at the same time as we were enhancing care delivery. But that's allowed us to kind of really focus on that culture of, you know, quality improvement, allowing us to measure standardized workflows, really kind of dig deep and look for opportunities and measure our success. Jill talked a little bit as well as Chad about the continuum. So we're, you know, again, it's really following the patient through all of the different, you know, sites of care and really making sure that we're supporting them. You know, and with that, you know, as we standardized information and data capture, including clinical data, it's allowing us to understand that clinical information as well as the claims data when we're looking at these programs. And then finally, I put on there, we're, you know, monitoring 60+ quality and utilization metrics just within our primary care population on a regular basis. And again, it is about creation of those metrics, sharing that information on a regular basis, and really to help drive that culture of quality improvement. Next slide for me, thanks. So, you know, we talked about CPC Plus, and I only threw this in here because I think it just kind of outlines just the different programs. And so, you know, if many of you are probably familiar with this wheel within the CPC Plus, but really talking about those programs. And so I kind of threw this on here as just kind of a general slide, but wanted to talk about a lot of the programs that we put in place, you know, throughout our journey. You know, when we look at access and continuity, you know, a lot has happened with e-visits, leveraging our patient portal, you know, now recently, you know, big push on telehealth and getting that stood up pretty quickly and being able to provide those services, as well as kind of that telephonic work. So really, you know, you look at this, a lot has happened over the last 10 years, really on how do we continue to outreach our patients and really engage them in between visits, because it's more than just when they walk through the door. So I would say there's been a lot of focus there specifically, with our episodic and chronic care management programs in order to, enhance our success when managing that patient population. The other thing I would mention is, with CPC Plus, we talked about, enhancing services. So we have implemented integrated behavioral health within our primary care practices. And so that really is providing that service as needed at the point of care, as well as, we've had dietitians in there, but really a heavy focus on social determinants of health, understanding the needs and being able to follow up with our community-based organizations as needs arise. And I think obviously, in the Kansas City area, there's a lot of effort going on there. That's kind of the next big opportunity, I think, as we look at that and understand capacity and understanding ways to address those needs. The other thing I would mention, we've talked about just the culture of quality improvement and really focus. We also are sharing that information, making that information available to our providers, performance, really working on point of care, getting information and scorecards directly accessible to them. That's kind of our focus. And enhancing tools within our electronic health record to kind of, again, help with clinical decision support as well as tools are available. And then finally, we've been focused a lot on, and it's the next slide, Jill, it's fine. The next slide really kind of reflects, we have been so focused on patient engagement, as far as the patients being in the center, we have really been focused on outreach, communications. We have patient family advisory committees for, all of our primary care, but also within our hospital setting, cancer center, as well. And so really leveraging, getting that direct feedback from our patients, engaging them in a lot of activities as we implement new things within the health system and within our primary care setting. So this is just a quick, just an overview of the things that we've been focused on. Again, just to kind of complete that picture, as we look at engaging and really advancing care delivery, our area of focus has really been in all of these areas, because really the patient's at the center. How do we give those extended services to our providers and care teams in order to help provide patients, quality of care and support their needs? So I went pretty fast. I talked, trying to move through pretty quickly because I know we're running out of time, but are there any questions for us, or we want to move on and get those at the end, Stacy?
Yeah, if anyone has any questions, feel free to submit them to the chat box. I'll keep us moving along so we have adequate time for our last speaker, and hopefully a little bit of discussion right at the end. So our next speaker will kind of be the one of the federal agency perspectives. Cindy Brock, who is Senior Healthcare Researcher in the Center for Evidence and Practice Improvement at the Agency for Healthcare Research and Quality, will be presenting on the Evidence Now model for providing external support for primary care. So thank you, Cindy.
Thanks very much. I'm just going to swap that. So I'm right at the right.
Perfect.
Yep. Okay, great. Well, yes. So we're going to shift gears a little bit here. I'm a bit of a woman out. I'm not in Kansas. I work for a federal agency, but anything I say is my own views, not that of the federal government. And I'm going to talk a little bit about the Evidence Now model for providing external support to primary care. I'll start with talking a little bit about the problem. Why are we talking about wanting to change provider behavior in the first place? Well, the truth is that providers don't always deliver evidence-based care, and we want to decrease that gap. But we can't expect them to change if nothing in their environment changes. The definition of crazy is doing the same thing over and over again and expecting different results. So something's got to change. What should that be? That was not the direction it was supposed to go. Let's try that again. So we've heard a lot from the other presenters about payment reform and value-based payment, ACOs, and aligning payment is really critical. but it's only one of the things that has to line up in order to get behavior change. One of the other factors can be non-financial motivators. So professionalism, clinicians want to take pride in their work. They've been socialized into a code of medical ethics, professional ethics. And as alluded to by Jill talking about the transparent sharing of performance information, they want to perform well vis-a-vis their peers. So that's one source of motivation. The other is they want to help people. They are genuinely care about their patients and about public health. And then I want to also mention the sort of fourth of the quadruple aim that Stacy talked about in her introduction, where primary care is in trouble. We're facing a lot of burnout that was happening before the COVID pandemic, and it's even a greater challenge right now. And so using sticks like financial penalties to punish poor performance or keeping on additional requirements may only serve to push more providers out of the workforce. Stacy and I, a long time ago, had a boss who used to say, I can pay my son $100 for getting an A, but if he doesn't know how to get an A, it won't matter. And that really is underlying the fact that aligning payment can remove barriers, but it won't trigger the provider change that you want if they don't know how to change. That payment reform is necessary, but not sufficient. And having incentives for specific health outcomes or specific processes tells them what they need to change, but they need to know how to make the changes. And that's where the Evidence Now model comes in. And you can see there are 5 components of the model. It's not rocket science. And Stacy mentioned a number of these elements in her introduction. So practice facilitation, which is called coaching as well. Health IT support, shared learning collaboratives, expert consultation, data feedback and benchmarking. And some of the other presenters have talked about this too, that these are come together, are complementary, all working towards trying to get providers to develop the capacity to make quality improvements. And we really think of practice facilitation here as the central and unifying strategy of the model. I have a colleague who likes to say that practice facilitation is the secret sauce to provider change. And we've noticed, we developed the model in our first round of Evidence Now, which was a multi-year ARC grant program, and it was focusing on advancing heart health. And we observed a number of benefits to the practice facilitation that was provided. So, increasing practices' capacity to implement the best evidence, connecting practices to information and resources and strategies to improve care, and also connecting them to community resources. We touched on social determinants of health and recognizing you're a part as a community that can support both patients and clinicians. Optimizing EHR use. There was a mention before about meaningful use and the challenges that practices have faced in using EHRs, and related to that, harnessing data for quality improvement. And that data can be EHR data and population-based data. It can also be things like small sample chart audits that you can use to decide whether a change you're trying out is really an improvement or where the missed opportunities are. And then finally, facilitators have been very helpful in helping practices navigate the inevitable disruptions, whether that is the EHR, a new EHR, or a change in clinician leadership or workforce turnover, that they've been helpful in that area too. And so ARC has tried to build the field of practice facilitation by developing a portfolio of products. One of these is a how-to guide, which is how to create a practice facilitation program. So if you're an organization that wants to start providing that kind of support to practices, how do you go about? What do you need to think about? That's what that guide is about. The other resources you see pictured here are all around the training of practice facilitators, beginning with a practice facilitation handbook, which provided training resources for people who wanted to run training sessions. And that was blown up to be an entire comprehensive curriculum on practice facilitation, including 32 modules on the skills and the different facets of practice facilitation. And finally, we are very close to launching a set of free online interactive modules that individuals who want to be practice facilitation or want to learn some of the skills of practice facilitation can take. So those are all resources about the skills that you need, people skills, technical skills to do the work of facilitation. But you also need to know where you're trying to guide those practices. What are the things that they need to be able to learn? And that's where we developed a key driver diagram in Evidence Now, using a lot of...
Sorry, Cindy, would you mind turning your volume up or speaking up? I think there's been a comment in the chat. Sorry to interrupt.
I'm sorry. I think it's just my volume. I do get commented.
Okay, sorry.
No, I really appreciate you interjecting.
Thanks.
Key driver diagram, which identifies the major drivers towards what is going to help practices build the capacity to do quality improvement work. And we identified a handful of drivers, and we actually heard from our cooperatives who were running these programs that we really needed to add engaging with patients and family, like we heard in our last presentation. So, and then we identified a number of change strategies for each of these drivers. And what we've done is put together a repository of tools and resources that were used in these facilitation programs, and curated those that were really the most promising, the easiest to use, and made this a searchable collection. So both practice facilitators and the practices themselves can lay their hands easily on resources that can help them. So you have in front of you the URL of that resource, and I will close that here so we can get some interesting discussion.
Wonderful. Thank you so much, Cindy. And thank you to all of our speakers. It looks like we have about 12 minutes left, so we'd love to open this up for some discussion, some Q&A. I will turn the Q&A portion over to my colleague, Christina Pacheco, who will kind of lead us through some of the questions. But in the meantime, also, if there's anyone that did not put any in the chat, you're also more than welcome to unmute yourself and to ask them aloud.
Yes, good afternoon. Are there any questions? It looks like a lot of them have been addressed in the chat. It does look like there was a question about Centris thoughts and conversations and activities around the role of social determinants of health and risk adjustment calculations.
Yeah, I'm happy to take a stab at that, and Chad and Joy, feel free to comment as well. Certainly social determinants are hugely important. I think we're understanding that more and more because of the experience of CPC Plus here and the strong work of Blue and his team and Chad's team there. Our clinics have been doing social determinant assessments for a long time and have, we're trying to figure out how to put that into the workflows, more soundly and more aggressively. And I know Joy works on that personally quite a lot, so she probably has some to add in here. In terms of the impact on risk adjustment, I think that's, we're still understanding how that works and how and if, that is impacting the risk score that we're getting from payers. I know that there are a number of commercial payers that use MARA, which is a tool from Milliman to help with risk adjustment. And so as a proprietary system, it's kind of whatever Milliman thinks its plans are for social determinants for a lot of the commercial contracts. And then for Medicare, that I think that's an evolving science too. We definitely think that has a place and certainly does impact at least the interventions that we're trying to produce. But I don't think we're all the way there yet in terms of understanding how to make that part of the value-based care equation. I personally feel like there's more we can be doing. Anybody else want to comment?
Yeah, I could chime in. So first of all, we've seen a lot more interest in social determinants of health since value-based care held people accountable for health outcomes. All of a sudden, people have gotten interested in things that are happening outside of the four walls of the clinic or the encounter. And that is a great thing. And we're also seeing in some systems where they are actually helping to pay for some strategies to address social determinants of health. But I think you need to think very carefully when you start talking about risk adjustment, because what you're doing when you risk adjustment for social determinants of health, which really don't mean social determinants of health, you really mean probably social risks of individuals that you're responsible for. You're saying it's okay to provide worse care to an individual because they have additional barriers. And so I would really encourage payers to try and think outside of the box of providing incentives to not, cream and cherry pick and turn people who have social challenges and social risks out of their practice, but still not give them a free pass card for not, getting them to their diabetes equally controlled as somebody else's diabetes.
I may just respectfully disagree just slightly on the impact of the risk score. I think, what we've learned in our experience in value-based care is that at least our providers don't feel there is a disincentive to providing care to high-risk patients. In fact, if you're as good as our providers think they are, they want patients, complex patients. They've already had them. They're happy to keep taking care of them. And risk adjustment allows them actually the opportunity to do quite well on those patients because of just how difficult.
Right. No, and I'm not talking about health risk. I'm talking about social risk. But yeah.
Yeah, I just, so I think Cindy, right to your point, it's great that we're all beginning to pay attention, right? And are building programs around addressing it. I think that's part of what I think is that's our first step, right? And then beginning to understand whether it's through risk adjustment or evaluation of the incentives, because the early incentives are just about, we've worked in part of our incentive on the medical home payment and the advanced primary care payment is just screening and infrastructure to get services to them, right? And so, but when I think about sort of how that works into the long term of either risk adjustment or an evolving incentive payment, I think we are so early in that and being able to understand impact. Really, it's just now getting our arms around so we can begin to evaluate. Yeah, and frankly, the infrastructure in the community, right? I mean, it's one thing to screen, but you've got to have infrastructure to hand off, right? And to provide, and that's a struggle for all of us.
Yeah, I think that is definitely in its infancy, right? And understanding and really building out those community-based organizations to understand who can accept it. I was just going to make a comment. I think as we continue to enhance our pre-visit planning activities and so forth, understanding barriers and so forth is very helpful to make sure we're getting patients in. So I think that's been extremely valuable as we prepare for the visit, just to make sure we understand needs as well. So.
Yeah, and it's because I agree with everyone, because it's kind of in its infancy, there's a lot of debate right now on the topic. There was actually a really good article that was just published last month in Health Affairs. Karen Joint-Maddox, who's presented at our forum in the past, and her colleagues, David Narenz and Austin, and they're kind of all emerging on this topic and kind of really breaking down different scenarios and how and what it means. And they're actually arguing that it can be a way in which we can provide more equity to these patients, as if, we actually reduce inequities. I mean, I think that's even the title maybe, but yeah, how we can actually promote equity in care. But yeah, I think it's a really interesting area and that we can keep exploring.
One of the other questions in the chat was about what are your thoughts on using CHART for Kansas rural hospitals? And Stacy had said that it's possible that maybe that was addressing the ACO transformation track. Tony, do you want to elaborate to make sure that we have your question clear?
Yeah, so can y'all hear me okay?
Mm-hmm. Yes.
Yeah, so hey, this is Tony Sunham, the Regional Chief Medical Officer for United Healthcare. I do think there's depending on where, the will of some of the rural health, either hospitals or health systems, in a aggregated model, there might be an opportunity under CHART for us to have a better, larger aggregation in that degree. So I would think that could be a possibility. We're going to continue to explore that, in particular here in Kansas. I think I silenced everybody. Either that or did I lose connection?
Nope, we heard you. I don't know if Betty, you wanted to elaborate anything that you knew about the CHART model or how it was built. It sounds like you had a little bit of insight into that, but that might be context.
Yeah. I think you're talking about the hospital-based portion, right? Or the community-based, and not necessarily the ACO, or it could be both. You could participate in both. But the community transformation part, I mean, the ACO transformation track is very similar to what the AIM model was that I described, but the community transformation is about, I think it's got to be a state Medicaid agency or some entity, maybe your entity, that brings together maybe different payers and recruits hospitals and sort of agrees to receive a cooperative agreement from CMS to kind of alternatively pay hospitals in a way that it's more like a global budget rather than the current model. So that means that if volume goes low, because everybody's avoiding the hospital, you're still receiving some minimum revenue. If volume goes high, you will have to share in some of that, but it's kind of a way to pad the hospital budget so that in rural areas where volume is such an issue, you don't end up losing hospitals when volume goes down. And it really relates to ACS because a lot of the savings that we found in the evaluation came from hospitalizations and came from knee visits, which is, you know, kind of taking away revenue from places that might already be strapped. So in some ways they can go hand in hand. And then the question is really that CMS has to get is like, the savings have to come from somewhere. And I feel like AC is it's almost, at least, you know, in the group that we looked at, we didn't really explore those implications for hospitals and the entities from which the savings came from and what those downstream implications are.
Yeah, thank you for that. So I think we're facing some of the similar things. The other questions I encourage all of us to do more thinking about is really having some hardwire attribution models. We continue to have attribution models without the true assignment PCPs. It's continues to sort of, in particular in the Midwest, without a hard-coded HMO capped in. So delegating.
Interesting.
So in order to be respectful of everyone's time, thank you to our speakers and to everyone who joined us today. This was an excellent presentation and conversation. And we look forward to having you all with us in June.
Great. Thank you all.
Thank you.
Thank you so much.
Thank you.
Thank you.